which was dead necrosed, and then the new cells are activated and they starts to resorb the bone, and then after 2 weeks you will feel the tooth movement. So if the light pressure is applied, there is a painless tooth movement within 2 days. If heavy pressures are applied, teeth will move, but after 2 weeks because undermined resorption happened there. So undermined resorption versus frontal resorption. Frontal resorption occurs when orthodontic forces are not exceeded the capillary pressure, whereas undermining resorption occurs when capillary pressure is exceeded and hyalinization occurs within the PDL. I explained clearly what is hyalinization. If you have any questions, please ask. If you understood, please let me know that you have already understood the undermined resorption and hyalinization. Effects of force distribution. Okay. Effects of force distribution. Thank you. And types of tooth movement. I'm sure you people know what are different types of tooth movement. Can you please tell me any two or three types of tooth movements? Yes, tipping. What else? Bodily movement, that is known as translation movement, torque, exactly. So what is the difference between tipping and torque? Tipping is the movement of the crown actually in one direction and the root in another direction, right? Bodily movement is the movement of a tooth in crown and root in the same direction up to the same amount, whereas torque is the movement of the root in one direction. So in tipping force, half of the PDL is loaded, means if you can see there's a triangular area in the diagram. The two triangular areas, one is near to the crest, the other is near to the apex. They are loaded. Forces used to tip the teeth must be kept low. For single rooted tooth, it should be around 50 grams or less to move a crown or tip a crown with frontal resorption. Bodily movement. If two forces are applied simultaneously to the crown of a tooth so that there is no net tipping movement, tooth can be moved bodily. Root, apex, and crown move in the same direction up to the same amount. To produce bodily movement, the required force is double to the tipping movement, right? And here the loading occurs only on the compression side, one side, and this area is larger than the area in tipping movement. Intrusion movement, here the lightest force is required. Approximately 5 to 10 grams of force is required. Why? Because here the force will be concentrated in the small area of the tooth apex. Extrusion, there is no net compression actually, there is only tension with the PDL. Heavy forces and pure tension would be undesirable unless the goal was to extract the tooth. Now, the effects of force duration and force decay. The key to produce orthodontic tooth movement is the application of sustained light forces. Clinical experience suggests that there is a threshold for force duration in humans that is how much 4 to 8 hours range, and that increasingly effective movement is produced if force is maintained for longer durations. That's why we tell the patients to keep wearing the appliances for 24 hours a day, but if they can wear it at least for 8 hours, the tooth movement can be achieved. Distribution of orthodontic forces by duration, and by force decay. There are three types of forces. One is known as continuous force, maintained at some appreciable fraction of original form. For example, if 50 gram of force is applied at visit number one, week number one, when you, in fixed appliances, in orthodontic braces, and you call the patient after 4 weeks, when he or she comes to you, at least 10 to 15 grams of force should be there. That is known as continuous force, means maintained at some appreciable fraction of the original form. Interrupted forces, the level declines to zero slowly. The example is also fixed appliances. For example, if we apply a power chain, initially the force level is 50 grams, but slowly it declines to zero till the patient comes to you at the next visit. For example, after 4 weeks. This is known as interrupted force. Intermittent force, the force levels declines abruptly to zero. Examples are removable appliances, headgears, elastics. The forces are maximum when the appliances are worn. Once you remove the appliance, it becomes zero abruptly. This is known as intermittent force. So, these are the types of forces classified according to the force decay. How the force goes off. So the most efficient tooth movement is achieved by light continuous forces. Heavy continuous forces should be avoided, but heavy intermittent forces, like in mastication, although less efficient, but clinically acceptable. A 4 to 6 or 8 week appointment cycle is the usual minimum in clinical practice. Why? Because there is a phase of lag phase where there is no movement, but the recovery should be there. Now, effects of drug effects on the response of orthodontic forces. Drugs that stimulate the tooth movement are unlikely to be encountered. Direct injections of prostaglandins in the PDL has been shown to increase the rate of tooth movement, but it is painful, like a bee sting. That's why they are avoided. Two types of drugs are known to depress the tooth movements orthodontically, and may influence current treatment. So the prostaglandin inhibitors, like painkillers, and bisphosphonates, which are used in osteoporosis patients. So any anti-inflammatory drugs can inhibit the tooth movement, but it depends on the dose and duration of the medicine. There are some ways to increase or accelerate the tooth movement. One of them is corticotomies. When we apply braces and we want to achieve the movement faster, what we can do is we can do the bone cuts teeth, around the teeth, which enhances the blood flow in that area and movement of the chemicals, resulting in more faster resorption and deposition. The other ways includes modified corticotomy, that is known as piezo with the blades. Microperforations can be done without incisions. These are the less invasive procedures, but definitely invasive procedure. And these procedures are mechanical procedures other than pharmaceutical, and they can accelerate the tooth movement by enhancing the blood supply of the area. Now, what are the side effects of orthodontic forces? Mobility and pain related to orthodontic treatment. A moderate increase in mobility is an expected response to orthodontic treatment to movement. Heavier the force, the greater the amount of undermining resorption expected, and the greater the mobility and not the movement. So, if the heavier forces are applied, you can feel the mobility but no tooth movement as such because of the undermined resorption. If heavy pressure is applied to a tooth, pain develops almost immediately as the PDL is literally crushed. So it should be avoided. The pain typically lasts for 2 to 4 days, then disappears automatically or with painkillers until the next appointment. Pain associated with orthodontic treatment is related to development of ischemic. Why the pain occurs? Because ischemic areas are developed and the nerves present in the PDL are crushed during forces. What are the effects of tooth movement or tooth forces on the dental pulp? Although pulp reactions to ortho treatment are minimal, there is probably a modest and transient inflammatory responses within the pulp that might increase the sensitivity. A large enough abrupt movement of the root apex could sever the blood vessels as they enter. Tooth vitality can be lost if root apex is pushed out of the cortical bone. So the effects are from minimum to maximum, depending on the magnitude of the force applied. Root resorption is one of the most undesirable side effect of the orthodontic tooth movement, but it happens. No matter how low or light forces are applied, but because we have to keep them for long durations, some of the orthodontic tooth resorption or root resorption is expected, should be expected. But it is, if it is less than 1 millimeter, less than zero point 0.4 millimeters, then it is okay. But if sometimes the root resorption can exceed up to the half of the root, depending on the root anatomy prior to treatment, and the forces and duration of the treatment. Moderate generalized resorption. Radiographic examination of individuals who have undergone comprehensive ortho treatment shows that most of the teeth have some loss of root length. That's okay. Greater in patients whose treatment duration was longer. Means if the heavier forces are applied for longer durations, chances of resorption is more. Severe generalized resorptions. Severe root resorption of all the teeth, fortunately, is very rare. But if there is evidence of root resorption before ortho treatment, patient is at considerable risk of further resorption during ortho treatment. So that's why we evaluate the patient periodontally first. If we find generalized resorption in the patient due to any reason, we try to delay or avoid treatment until it is fixed. So, various reports have suggested that above average resorption can be anticipated if the teeth have conical roots with pointed apices, that is natural, distorted form like dilacerations due to any trauma before in life, or a history of trauma with or without orthodontic treatment. More severe resorption can be expected during orthodontic treatment. Severe localized resorption. In contrast to severe generalized, severe localized resorption usually is caused by orthodontic treatment. The best way to detect those are likely to experience with the unusual large amount of resorption is to take panoramic radiograph within 6 to 9 months of treatment start and then evaluate the patient periodically. Now, the effect of treatment on alveolar bone. Fortunately, excessive loss of crestal bone height is almost never seen as a complication of ortho treatment. Less than zero point 0.5 millimeters and almost never exceeding 1 millimeter, with the greatest changes occurring at extraction sites, especially the sites where the extraction happened. Even adults who have had bone loss from PDL disease can have orthodontic treatment with good bone responses if the periodontal diseases are well controlled. Enamel demineralization. It is one of the side effect of the ortho treatment. Yes, maxillary incisors, particularly lateral incisors, have the greatest likelihood of obvious demineralization. Why it happens? Risk factors were a young age at the beginning of treatment, poor hygiene before the start of treatment, and citation poor hygiene during treatment. They can cause enamel demineralization. So, thank you very much for your presence and attention. Those who have attended the lecture, if you have any questions, you can ask anytime before your exam. During exam, questions are not allowed. So, please ask before the exam starts. You're welcome.